Maxillary Anesthesia, Injection Techniques, with Dr. Morton Rosenberg, Professor of Oral and Maxillofacial Surgery, Head, Division of Anesthesia and Pain Control, Tufts University School of Dental Medicine, and Associate Professor of Anesthesiology, Tufts University School of Medicine. And Dr. Joseph A. Giovannitti, Jr., Professor and Chair of the Department of Dental Anesthesiology, Director of Anesthesia, Center for Patients with Special Needs, University of Pittsburgh School of Dental Medicine.
Local anesthesia of the maxilla is commonly achieved by supraperiosteal injection. This technique works well because the comparatively thin and porous nature of the alveolar bone permits the local anesthetic to reach the nerve fibers innervating the teeth and surrounding periodontium. Supraperiosteal injections can be used singly to anesthetize individual teeth or in combination over an entire quadrant. Individual supraperiosteal injection techniques will be described later in this program. On occasion, profound anesthesia may not be obtained, especially in the region of the maxillary first molar, where dense bone may impede distribution of the anesthetic. In cases of acute inflammation or infection, supraperiosteal injection may be ineffective or even contraindicated. 3 other approaches for anesthesia in the maxilla may be alternatives to the supraperiosteal technique and are described in this program: the infraorbital, the posterior superior alveolar, and maxillary or second division nerve block. These techniques are easily learned and can be especially helpful with procedures involving multiple teeth.
Anatomy. The oral cavity receives innervation from the trigeminal, or the fifth cranial nerve. The sensory cell bodies of the nerve form a large half-moon-shaped ganglion called the trigeminal, semilunar, or Gasserian ganglion, which is situated in the trigeminal depression of the middle cranial fossa. Originated from the trigeminal ganglion are 3 large nerve trunks: the ophthalmic, V1, the maxillary, V2, and the mandibular, V3. The maxillary division of the trigeminal nerve is exclusively sensory and innervates the skin of the middle portion of the face, lower eyelid, side of nose and upper lip, the mucosa of the nasopharynx, maxillary sinus, soft palate, tonsil and hard palate, and the maxillary teeth, periodontium, alveolar bone, and gingiva. The maxillary nerve exits the cranium through the foramen rotundum to reach the pterygopalatine fossa, where it gives off several branches: the zygomatic nerve, the pterygopalatine nerve, and the posterior superior alveolar nerve. The zygomatic nerve enters the orbit through the inferior orbital fissure. Its branches supply the skin on the side of the forehead and prominence of the cheek. A small branch communicates with the lacrimal nerve of the ophthalmic division to carry secretory fibers to the lacrimal gland. The short pterygopalatine nerve trunks descend vertically to course through the pterygopalatine ganglion. Branches of the pterygopalatine nerve emanating from the ganglion distribute sensory fibers to the midface. These branches include the orbital nerves and posterior nasal nerves, which innervate the ethmoidal and sphenoidal sinuses, periosteum of the orbit, nasal turbinates, and posterior nasal septum. One of these branches, the nasopalatine nerve, passes downward and forward on the nasal septum, enters the incisive canal, and reaches the oral cavity via the incisive foramen to provide sensation to the palatal mucosa of the premaxilla. A pharyngeal branch also exits the ganglion posteriorly to serve portions of the sphenoidal sinus and mucosa posterior to the auditory tube. Palatine branches of the pterygopalatine nerve pass down the pterygopalatine canal and exit via foramina on the posterolateral aspect of the hard palate. The greater or anterior palatine nerve emerges through the greater palatine foramen to supply general sensation to the soft tissues of the hard palate and palatal gingiva. The other branches exit from the lesser palatine foramina and innervate the soft palate, uvula, and tonsillar area. The posterior superior alveolar nerve is the last branch to leave the maxillary trunk within the pterygopalatine fossa. Before it enters the maxilla, gingival branches are given off to innervate the buccal soft tissues of the maxillary molar and tuberosity region. The nerve then enters the maxilla and continues down the posterior wall of the maxillary sinus, ultimately contributing fibers to the superior dental plexus. The posterior superior alveolar nerve innervates the maxillary molar teeth, with the possible exception of the mesiobuccal root of the first molar, the surrounding periodontium and adjacent buccal mucosa, and the mucous membrane of the maxillary sinus. The maxillary nerve trunk becomes the infraorbital nerve once it crosses the inferior orbital fissure to travel within the infraorbital groove and canal. During its course, the anterior superior alveolar nerve is given off. After contributing to the superior dental plexus, it provides pulpal innervations to the incisors, canine and often premolars, their periodontium and facial gingiva, and the anterior portion of the antrum and floor of the nasal cavity. If present, the middle superior alveolar nerve supplies sensation to the premolar region and the mesiobuccal root of the first molar. The infraorbital nerve emerges from the infraorbital foramen to divide into its terminal branches. The inferior palpebral branches supply the lower eyelid, the external nasal branches provide sensory innervations to the side of the nose, and the superior labial branches pass to the upper lip. Armamentarium.
Patient safety and comfort rely on several factors, including the armamentarium used for local anesthesia, proper patient positioning, and the application of a topical anesthetic prior to injection. When used correctly, the single-dose cartridge, sterile hypodermic needle, and aspirating syringe combine to ensure accurate placement of the local anesthetic solution with minimal risk to the patient. For most maxillary blocks, the 25-gauge long needle is generally preferred.
When the depth of needle insertion is less than 2 centimeters, the 25 or 27-gauge short needles are suitable alternatives. Proper care and handling of contaminated needles and cartridges will reduce the risk of sharps exposure to the patient and clinician. Needles should be immediately covered by a protective shield using a one-handed scoop method after use to prevent accidental needle stick with the contaminated needle. Besides using the needle cap, several recapping devices are available to assist with this recapping. Recapping devices come in cardboard, metal, and plastic materials. Approved sharps containers are mandated to dispose of contaminated needles, cartridges, and other sharps. The containers should be properly disposed of according to federal, state, and local regulations. Topical anesthesia. To desensitize the mucosa before needle insertion, a topical anesthetic is applied to the injection site. The mucosa is first dried with a sterile gauze and a small amount of topical anesthetic is then placed with a cotton-tipped applicator. After the anesthetic agent has had time to take effect, it will result in mucosal anesthesia to a depth of 2 to 3 millimeters. Residual anesthetic and surface debris are removed with a sterile gauze immediately before injection. Injection techniques. Infraorbital nerve block.
The infraorbital nerve block will anesthetize in one injection all peripheral branches of the infraorbital nerve, the anterior superior alveolar nerve, and often, when present, the middle superior alveolar nerve. At times, local anesthesia can be obtained from the central incisor to the mesiobuccal root of the first molar. The target site for the injection is the infraorbital foramen. Although several approaches have been described, the vertical approach is the safest and most commonly used.
Before injection, it is important to locate the infraorbital foramen. When the patient is looking straight ahead, a line drawn vertically from the medial aspect of the pupil will overlay the foramen. The foramen is identified by palpating the infraorbital rim and feeling a notch or roughness corresponding to the zygomatic comaxillary suture. Then, sliding the finger inferiorly 5 to 10 millimeters will bring it to rest in a depression containing the infraorbital foramen. Anatomically, the pupil, infraorbital notch, and infraorbital foramen lie in a straight line. For a right-handed operator performing a right infraorbital nerve block, the clinician should be seated in front of the patient with the patient's neck extended and the head turned to permit visualization of the right premolar region. The mouth may remain closed. The left index finger is placed over the infraorbital foramen and the upper lip is retracted by the thumb, pulling taut the tissues in the mucobuccal fold. The needle is then inserted vertically about 5 millimeters lateral to the second premolar and parallel to the long axis of the tooth with the bevel of the needle towards the face. The orientation of the needle as seen from the front of the patient should mirror a vertical line, defined by the medial aspect of the pupil and the infraorbital foramen. For this and other injections described in this program, a few drops of anesthetic expressed as the needle is slowly advanced is useful to minimize discomfort. The average depth of penetration is about 15 millimeters. After negative aspiration, injection is made with a palpating finger remaining in place to help guide local anesthetic solution into the infraorbital canal. A total of 1 milliliter, or about 1/2 of a dental cartridge, is injected slowly. As with all other injections, the needle is then slowly withdrawn and recapped. Because of crossover fibers from the contralateral side, anesthesia of the central incisor may be incomplete unless a supraperiosteal injection is made over that tooth. An important advantage of this vertical approach is that the overhang of the infraorbital rim protects the eye from accidental needle puncture. Correct orientation of the needle bevel during insertion offers two potential advantages. First, if bone is contacted prematurely, the heel of the needle bevel will tend to glance gently off the bone without scraping the periosteum. Second, the spread of anesthetic into the foramen and canal may be aided. For a right-handed operator performing a left infraorbital nerve block, the clinician should sit in the 11 o'clock position, this time with the patient's head turned toward the operator side. The left thumb is used to palpate the infraorbital foramen and the index finger is used to reflect the upper lip. For the left-handed operator, the mirror image of the techniques illustrated in this video may be used. Posterior superior alveolar nerve block.
The posterior superior alveolar nerve block is used to produce anesthesia of the posterior maxilla. Usually all 3 maxillary molars are anesthetized, along with the surrounding periodontium and maxillary buccal mucosa. However, a separate supraperiosteal injection over the maxillary second premolar or mesiobuccal root of the first molar may be required to ensure complete anesthesia of the first molar. This injection is generally referred to as the middle superior alveolar and will be discussed later in this program. The target site for the posterior superior alveolar nerve block lies on the posterior aspect of the maxilla, about 1 centimeter above and medial to the apices of the third molar. The nerve enters the maxilla here through 1 or more foramina. Because this area is convex, the needle must be oriented in a backward, upward, and inward direction.
For a right-handed operator performing a right posterior superior alveolar nerve block, the clinician may be seated in the 8 o'clock position, with the patient's neck extended and the head turned to permit visualization of the maxillary buccal vestibule. To perform a left posterior superior alveolar nerve block, the right-handed operator should sit in the 11 o'clock position. This maneuver relieves tension on the cheek and moves the coronoid process away from the injection area. The needle puncture point is in the height of the vestibule immediately behind the zygomatic process. It is normally situated between the distal buccal root of the second molar and the mesiobuccal root of the third molar. The zygomatic process is easily identified by gentle palpation buccal to the first molar. As the probe is moved posteriorly, It falls behind the process, indicating the insertion site. The distal boundary of the zygomatic process is palpated. The needle is carefully advanced to the insertion point and oriented medially as well as posteriorly and superiorly. For the average adult, the needle access should be at an angle of 45 degrees to all three planes. The needle is slowly advanced to a depth of 15 millimeters. After careful aspiration, 1/2 to 1 cartridge of anesthetic solution, or about 1 to 1.8 milliliters, is slowly injected. With the proximity of the posterior superior alveolar artery and the pterygoid venous plexus, hematoma formation is a potential complication. This risk, quite low with proper technique, is increased if the needle is inserted too far laterally and especially if it is redirected while embedded in tissue. Both errors tend to occur when the operator allows the cheek to torque the syringe medially during injection. If the insertion point is too anterior or too close to the alveolar process, or if the angulation is too vertical or too medial, premature contact with bone will occur. In these situations, the needle should be withdrawn and correctly repositioned for a new insertion. As stated previously, a separate supraperiosteal injection over the maxillary second premolar or mesiobuccal root of the first molar is required to ensure complete anesthesia of the first molar. This is the middle superior alveolar field block. The middle superior alveolar field block will anesthetize structures innervated by the middle superior alveolar nerve when present, and its terminal branches, to include the pulps of the maxillary first and second premolars and their facial soft tissue. For a right-handed operator performing a middle superior alveolar injection, the clinician may be seated in the 8 o'clock position for the right side or 9 o'clock position for the left side. For a left-handed operator, the clinician may be seated in the 4 o'clock position for the right side or 3 o'clock position for the left side. The alveolar mucosal tissue is palpated at the injection site in the vestibule at the height of the mucobuccal fold superior to the apex of the maxillary second premolar to ensure only soft tissue is injected. Using a 27-gauge short needle, orient the syringe parallel to the long axis of the tooth with the large window facing the operator. Insert the needle at the height of the mucobuccal fold at the apex of the maxillary second premolar, approximately 1/4 of the depth of the short needle, about 5 millimeters, or until the bevel is slightly superior to the apex of the tooth. Aspirate within 2 planes. Slowly deposit 0.9 to 1.2 milliliters of solution, about 1/2 to 2/3 of cartridge, over 60 to 90 seconds. Other nerve blocks. If anesthesia is required in the maxillary anterior teeth, the anterior superior alveolar nerve block may be used. The anterior superior alveolar nerve block anesthetizes structures innervated by the anterior superior alveolar nerve, including the pulps of the maxillary central incisor through the canine on the injected side and their facial periodontium. For a right-handed operator performing the anterior superior alveolar nerve block, the clinician may be seated in the 8 o'clock position, or the 4 o'clock position for a left-handed operator. Palpate the alveolar mucosa tissue at the injection site in the vestibule at the height of the mucobuccal fold superior to the apex of the maxillary canine, just anterior to and parallel with the canine eminence, to ensure only soft tissue is injected. Using a 27-gauge short needle, orient the bevel of the needle away from the large window of the syringe to ensure the bevel orientation is toward the bone. Place the syringe parallel with the long axis of the tooth. Insert the needle at the height of the mucobuccal fold at the apex of the maxillary canine, just anterior to and parallel with the canine eminence, and an approximately 10-degree angle off an imaginary line drawn to the long axis of the tooth. Aspirate in 2 planes prior to injection. Slowly deposit 0.6 to 0.9 milliliters of solution, about 1/3 to 1/2 of cartridge over 30 to 60 seconds. Greater palatine nerve blocks are indicated for pain management of palatal soft and osseous tissues distal to the canine in one quadrant. Assume the operator position for the right-handed operator at the 8 or 9 o'clock position or 11 o'clock position for the left side. A left-handed clinician will assume the 3 or 4 o'clock position for the right side or 1 o'clock for the left side. Locate the greater palatine foramen by gently sliding a cotton-tipped applicator along the hard palate surface, starting at the junction of the maxillary alveolar process and the posterior hard palate near the maxillary first molar. Move distally until the cotton-tipped applicator falls into a depression, the greater palatine foramen. Using a new cotton-tipped applicator in the non-dominant hand, apply firm pressure with the cotton-tipped applicator directly over the depression to provide surface pressure anesthesia. Using a 27-gauge syringe, direct it from the contralateral side of the mouth at a 90-degree angle to the palate toward the cotton-tipped applicator. Insert the needle slightly anterior to the greater palatine foramen 3 to 6 millimeters until the palatine bone is contacted. Aspirate, slowly depositing approximately 0.45 milliliters of solution, about 1/4 of the cartridge. Nasopalatine nerve blocks are indicated for pain management of palatal soft and osseous tissue in the anterior third of the palate, approximately from canine to canine. Assume an 11 o'clock position for the right-handed operator and a 1 o'clock position for the left-handed operator. The deposit location or target area for the nasopalatine nerve block is the incisive foramen beneath the incisive papilla. The injection site is the palatal tissue lateral to the incisive papilla, which is located at the midline. Never insert the needle directly into the incisive papilla, because this can be extremely painful. Pressure anesthesia is performed utilizing a cotton-tipped applicator on palatal tissue on the contralateral side of the incisive papilla. Insert the needle into the previously blanched tissue at a 45-degree angle to the palate. Advance the needle until the maxillary bone is contacted and then the injection is administered. Aspirate and slowly deposit 0.45 milliliters of solution, about 1/4 of the cartridge, over 20 to 30 seconds. Maxillary nerve block.
The maxillary or second division nerve block will anesthetize the entire hemimaxilla with a single injection. The target of the injection is the maxillary nerve as it passes through the pterygopalatine fossa.
3 approaches to the maxillary nerve block are possible. The high tuberosity approach is the easiest to perform technically and the least likely to cause discomfort, but is the most likely to cause a clinically significant hematoma. The pterygopalatine canal approach ensures accurate placement of the needle provided it can be successfully inserted up the canal. This injection also requires a separate palatal infiltration to minimize discomfort. The extraoral approach, in which the pterygopalatine fossa is accessed percutaneously, requires disinfection of the skin, is rarely used, and will not be demonstrated. The high tuberosity approach is almost identical to the posterior superior alveolar nerve block, except that the needle is inserted much deeper and slightly more medially to enter the pterygopalatine fossa via the pterygomaxillary fissure. Insertion is at the height of the mucobuccal fold, just behind the zygomatic process, in an upward, inward, and backward direction. With proper orientation, the needle tip will come to rest at or within the pterygopalatine fossa, slightly lateral to and about 1 centimeter below the maxillary nerve. Clinically, the 25-gauge long needle used for the injection can be bent 30 degrees at the hub to facilitate medial insertion. Because this action weakens the needle, the patient must be cautioned to remain still during injection, and the needle must be advanced gently through tissue. The 8 o'clock position may be used for the right high tuberosity block and the 11 o'clock position may be used for the left. The patient's neck is extended and the head turned to permit visualization of the buccal vestibule. A finger is used to palpate the zygomatic process. The mouth is partially closed and the jaw is shifted toward the side of injection. With the palpating finger placed over the zygomatic buttress, the needle is carefully moved into position. The needle tip is inserted in the height of the vestibule as previously described, and slowly advanced superiorly, medially, and posteriorly along a straight path to a depth of 30 millimeters for the average adult. After a negative aspiration, the entire contents of the 1.8 milliliter cartridge is slowly injected. Premature contact of bone requires that the needle be withdrawn before being reoriented to minimize the chances of hematoma formation. A positive stop against bone near the final depth of insertion probably means that the needle has impinged on the pterygoid plate. In this case, the needle should be withdrawn slightly, a negative aspiration obtained, and the anesthetic solution injected. Anesthesia will often be obtained because of medial spread of the solution. If it is not, re-injection along a slightly more medial pathway can then be performed. Pterygopalatine approach. The pterygopalatine approach to the maxillary nerve block uses the greater palatine foramen as the insertion point and the pterygopalatine canal to guide the needle to its target. The foramen is usually located adjacent to the alveolar bone between the distal half of the second molar and the mesial half of the third molar. The pterygopalatine canal travels upward and backward to reach the pterygopalatine fossa. When the needle is inserted to a depth of 30 millimeters for the average adult, the tip will lie 1 centimeter beneath the maxillary nerve. For this injection, a 27-gauge long needle is preferred. The smaller diameter and greater flexibility of the 27-gauge needle facilitates passage through the canal. With the bevel facing down, the needle is bent upward 30 degrees at the hub. Then, as the needle is inserted upward and backward through the greater palatine foramen, the heel of the bevel will tend to contact the posterior wall of the pterygopalatine canal, allowing the needle to deflect anteriorly. Should the needle tip strike bone, there is a likelihood that it cannot be advanced and must be redirected. The right pterygopalatine canal injection can be made with the operator in the 8 o'clock position. The left side can be injected with the operator in the 11 o'clock position. To provide visibility, the patient should extend the neck and open the mouth widely. Greater palatine foramen can be identified by placing a round probe at the junction of the maxillary alveolar process and hard palate. As the probe is moved posteriorly from the second molar, it will appear to fall into the fovea created by the foramen. Topical anesthesia of the hard palate is not easily achieved with conventional preparations. Additional anesthesia may be obtained by applying pressure to the injection site with a cotton-tipped applicator. After about 20 seconds, the needle is inserted into the foramen as pressure is maintained and 0.1 to 0.2 milliliters of anesthetic solution is slowly deposited. After waiting 2 or 3 minutes, the needle is advanced slowly through the greater palatine foramen and up the pterygopalatine canal. A pen grasp of the syringe facilitates the gentle probing that may be necessary to navigate the canal. The needle is never forced. If resistance is felt, the needle should be withdrawn slightly and advanced at a different angle. Following needle insertion to the proper depth and negative aspiration, a full cartridge of anesthetic solution is slowly administered. Perhaps 1/10 of canals have bony obstructions that may prevent passage of the needle. If the canal cannot be negotiated, then the injection should be aborted. Excessive force can lead to needle breakage, perforation of the thin medial wall of the canal, or deflection of the needle laterally into the infratemporal fossa. If the needle pierces the medial wall of the pterygopalatine canal and enters the nasal cavity, air will be drawn back into the syringe during aspiration. If the needle is advanced too high in the pterygopalatine fossa, as can happen in children and small adults, blockade of the nerves supplying the orbit can occur. This rare complication can result in diplopia and even temporary loss of vision. The patient should be advised that these effects are transient and will disappear as the local anesthetic dissipates.
Successful and safe local anesthesia is the foundation of modern clinical dentistry. Only with a thorough understanding of local anesthetic techniques and their anatomical basis can we accomplish our goal of providing high-quality dentistry in a pain-free environment.